It's my pleasure tonight to introduce our moderator, Dr. Hunter Vincent. Dr. Vincent is a pain management and regenerative medicine specialist and the director of clinical research at Ortho Healing Center in Los Angeles. He has authored several peer-reviewed publications and multiple textbook chapters on orthobiologics in sports medicine and pain management. Dr. Vincent is also the annual moderator at the Orthobiologic Institute, a premier symposium that gathers the world's foremost experts in tendon, cartilage, and spine disease. Dr. Vincent, welcome, and thank you so much for joining us tonight.
Hey there, everyone. It's my pleasure to be here, and I'm super happy to moderate this Below the Waist Joint Pain Solutions webinar. Before we launch into it, I'd like to introduce our expert panelists that'll be joining us virtually tonight, and then we'll open up the floor and try to answer all of the questions that you may have. So our first panelist that will be joining us is Dr. Nikki Weiner. She is a licensed occupational therapist who is clinical director, president, and co-founder of the Rising Workplace, which provides comprehensive ergonomic injury prevention and EHS solutions across the full spectrum of workplace environments. She earned her bachelor's degree in biological sciences from the University of Georgia and a doctorate of occupational therapy at Washington University. Her professional work has been published in the American Journal of Occupational Therapy, Business Insider, Today and OT Magazine, and the New York Times. I'll give a small virtual welcome for her. Excellent. Moving on to panelist number 2, we have Dr. Patrick Berner. He is a physical therapist and registered dietitian nutritionist practicing in upstate South Carolina. He's one of only a few individuals in the country who holds this combination of credentials. His company, Physio, focuses on providing quality education, consulting, and coaching for general health and well-being of individuals with an emphasis on human movement and nutrition. Dr. Berner is currently adjunct faculty for Doctor of Physical Therapy programs at Baylor University, South College, DeSales University, and Anderson University, where he provides content knowledge related to nutrition, digestion, metabolism, and general health promotion. He currently serves as chair of APTA Health Promotion and Wellness Council and is an advocate for physical therapists' involvement in population health. We are very excited to have him on this panel as well. And last, but certainly not least, we have Dr. Rachel Thompson. She is an adult and pediatric orthopedic surgeon who specializes in neuromuscular orthopedics, cerebral palsy, and hip dysplasia and disease. She's on staff at the Orthopedic Institute for Children and serves as an assistant clinical professor in residence in the Department of Orthopedics at UCLA. She also serves as the director for the UCLA/OIC Center for Cerebral Palsy and the William and Patricia Oppenheim Presidential Chair in Pediatric Orthopedics. She has received various awards for her research, including from the American Academy of Cerebral Palsy and Developmental Medicine, the American Academy of Orthopedic Surgeons, and the Orthopedic Research Society. We are ecstatic to have her on this panel tonight, and we look forward to hearing their responses to all the questions that are already coming through. So I think to kick off the event, we'll send the first question over to Dr. Berner. Now, the question that we have coming through here is best joint-specific exercises, knees, hips, low back, ankles, to strengthen joints, improve mobility, and reduce pain. Now, I know that that is a very broad question, but what are your thoughts on any joint-specific exercises to kick us off?
Yeah, so when it comes to joint specific, I'm actually going to go with kind of looking at weight-bearing multi-joint exercises. So you're looking at things specifically to the lower body, things like squats, deadlifts, okay, hip hinges, right? Kind of loading. That's really an interesting, question though, because you can say let's squat, let's deadlift, but you also have to look at the importance of finding kind of that sweet spot to actually load the body to where you're facilitating that functional strength component, but that you're also facilitating the health of that joint. So for me, I typically like to do gross kind of, like I said, multi-joint strengthening instead of isolated strengthening.
I think that's a good point. I think, as I apply that to to my practice, I think a lot of times I see that patients' biomechanics can be altered in that sense. And so more of the multi-joint functional movements, especially with someone who can educate the patient and cue them, can provide more biomechanical stability in that sense. So whether that's strengthening the glutes or strengthening the hips. Dr. Thompson, what do you think about that?
So I was going to say, I entirely agree. You know, we see patients all the time, specifically in our gait analysis, where we're kind of looking at all of these problems, and we see that everything really is interactive. So if there's a problem in the knees, we see them in the way that the hips move. If there's a problem in the way that the ankles move, we see it in the way that the knees and the hips are loading. So that is really key. All those functional movements will help you kind of offload the joints kind of collectively.
Do you think that, you know, and this is kind of an open question just to piggyback on all that, but, you know, I find that glute weakness or glute activation, so to speak, is certainly a weakness for many patients that walk into the clinic. Would you agree with that as well?
Yeah.
Dr. Thompson, to go back to you.
Yeah, I was going to say, I entirely agree. I think the biggest problem we see in patients who have early arthritis is that they do have that glute weakness, both in the weakness that helps you extend through kind of your back and your hips, and the stabilizers, the glute medius. And those are really hard muscles to strengthen, I find, for patients to isolate and strengthen. So I'm actually interested to see what Dr. Berner has to say, you know, what he recommends, because I just recommend that patients do like Pilates videos because I think it's low impact, but certainly I'm not a physical therapist, so I actually am interested as well.
Yeah, so it's definitely kind of trying to use those functional strengthening movements, right? But it does for a particular patient, right? You've got to find a way to strengthen it that is enjoyable to them, right? You've got to find activities that they find enjoyable so that they, you know, continue to do it. Because traditionally people think, you know, when you want to strengthen glute med, right? So you think about the muscle on the side of your leg that brings it out. People don't want to lay down and do clamshells and do, you know, sideline raised kicks. You know, that's not enjoyable to people. So it's trying to find ways that it's also enjoyable, but, you know, loading that joint. And again, for me, I think things like deadlifts, things like hang cleans, squats, box jumps, if appropriate, right? There's things that we can do to really load those joints more appropriately.
And I could add in, now speaking about functional movement, this is something that I teach many of my clients, specifically those of us who have a job where we're sitting most of the day, to practice that hip hinge, everything you do in your daily life, when you're unloading the dishwasher, when you're taking the clothes out of the dryer. If you practice that movement at the hips, you'll experience more flexibility of the hamstrings, which can have a big impact, specifically in lower back pain. And so when we work on that hamstring flexibility, especially for those of us who are more sedentary, and in fact, it's a pattern in Western culture that we see quite frequently, as you know, is that hamstring tightness, and that can cause some back pain.
And Dr. Weiner, can you elaborate a little bit more on the hip hinge? Because I do think that's a really valuable movement for people, but when you say hip hinge, maybe not everyone knows exactly what that is.
So there's a great article I love to reference, and if you just search The Lost Art of Bending, there's an NPR news article that I like to direct everyone to, and I could even demonstrate here because I frequently do this. But rather than if you drop something on the floor, I think naturally our head goes down, our spine curves, and it's just something that happens out of habit. But if we work on that movement, instead coming from the hips, sending our hips back, keeping our back flat, we automatically feel the pull on the back of the hamstrings. So it's a more effective, safe movement. And it's something that we can do literally every day with all the tasks that we do. And it just has to do with the motion being at the hips rather than at the back. And then of course at the knees to get a little bit more leverage.
And I think that, you know, to get back to what Dr. Berner was saying, that is the primitive movement, essentially, that's key for a lot of the functional exercises that he was talking about as well. So again, full spectrum there from an ergonomic standpoint and also from a therapy and exercise standpoint. So all one and the same. Now, to piggyback on that kind of discussion, one of the other questions that's come through is are there limitations on physical activity during a flare-up? So when a patient has an exacerbation of their pain, how do you recommend that they push through that. And let's start from the more surgical patient, Dr. Thompson, and I'll kind of ping that to you, and then we can send it back down the conservative chain, so to speak.
So from a surgical standpoint, if you're, any pain that you're having, typically you're not going to make anything worse by the exercises that you're doing. As far as kind of physiologically, you're not going to make the cartilage disease worse by pushing through, within limits. I wouldn't say go run a marathon, but doing your regular strengthening and range of motion exercises are not going to make the disease process worse. But you really need to kind of work towards your limit, and using, we recommend typically using kind of things like ibuprofen, heat, or ice, depending on which feels better for you and gets you ready to exercise. And then you can push yourself within limits. But certainly from a disease process standpoint, you exercising from our standpoint of, orthopedically, you're not going to make things worse. And it's really just a matter of how much you can tolerate and how, if it's going to make you feel better. Certainly we would never recommend just laying in bed like we used to, 20, 30 years ago, of saying, oh, well, you should have bed rest if you're in pain. That's certainly not what we're recommending now.
I'm sure Dr. Berner and Dr. Weiner also agree with not lying in bed 24 hours a day, but I'll let Dr. Berner, why don't you elaborate on that as well?
Yeah, no, I definitely agree. So kind of looking at that question, right, as far as if there's a flare up, should we stop activity? And to Dr. Thompson's point, no. It never truly reaches a point that we need to stop, because even if you're having difficulty at that one location, there is always a way to stress the human body to continuously reap the benefits of physical activity and movement. Okay. And it really comes down to modification of that activity or task that you're working on. So it's not the bed rest. So, if your knee's bothering you for something, there's certain other activities we can start to work on and to continue strengthen and maintain your conditioning, right, without targeting that joint. So it's never sitting around in bed. It's just getting up and moving, but modifying that activity to kind of meet you where you are.
Yeah, absolutely. I can chime in if you'd like.
Oh. Go ahead. Yeah, go ahead, Dr.
Sorry.
Weiner.
Okay. When Dr. Berner is talking about task modification, that's everything in the field of occupational therapy. And so it's not that you're unable to do an activity. It may just be either modifying the way you do that activity, using a different tool or device. I like to give the example of maybe putting on your shoes. That's a really difficult activity if you're having some hip and joint and knee pain. But if you had something like a long-handled reacher and a shoehorn, you can still do that activity. So sometimes it's rethinking the activities that we do and how we can still perform them. And then also planning ahead. So when it comes to that activity, kind of strategizing and pacing the day so that you still have energy at the end of the day to complete your basic self-care activities and the things that you need to do. So being smart and thinking ahead is a great way, especially when you're having a flare up, and thinking about alternate ways to do your daily tasks.
Yeah, I think those are all great points. A lot of times, patients will say, walking bothers me or squatting bothers me if we're talking about knee pain. And that's okay. That's fine. We have to work around the pain, right? But the pool may not be bothersome. Water aerobics may not be bothersome. Pilates, yoga, Tai Chi. I mean, to your point, to all of your points, there are other ways to maintain your exercise for the week, and along with that are a myriad of different health benefits from a physical and a mental standpoint. So I think just because one road is blocked, there are a million other roads that, we can go down. And so that kind of leads to the next question, which is, well, when do you know that it's okay to push through the pain? I get that a lot, and I'll kick us off with kind of what I see, or I guess what I say. So when a patient says, well, what's good pain and what's bad pain? And I think I always encourage people, to your point, Dr. Thompson, to stay within their limits, right? And stay within, where they feel comfortable and they can stay safe, especially in the setting of chronic pain, because the last thing you want to do is push beyond your limits and then get injured in another way, right? That's counterproductive to any success. I don't care who you are. But I think, in regards to joint pain, if you have a little bit of joint stiffness and you start to exercise and it goes away, almost like you get warmed up, I consider that okay. Now, if you're exercising and the soreness and the pain is lasting for longer than that 24 to 48 hours, then that's probably pushing beyond your limits, and we need to throttle back or change the activity in a sense. Now, that's very broad, but I think sometimes that can help patients kind of figure out where their confines are a little bit. Dr. Weiner, what do you think?
Yeah, I agree. And I think that oftentimes it's been my patients who are the true experts on this through experience. And so it's really about kind of tuning in to what your body is telling you, listening to those early signs of discomfort, taking note when you escalate into more of a full pain episode, and thinking about the pattern there. And then when you can really track that, then you can prevent it in the future. So being able to be aware of your triggers, be an expert on your own condition.
Excellent. Dr. Berner?
Yeah, I would definitely second that. I mean, and when it also comes to kind of pushing through that pain, I think it's also important to kind of being aware of, all of the cardinal signs of inflammation that may be going on, right? To where it's not just pain, but if there is, that redness, swelling, heat, or really a true loss of function, that's where we kind of have a little bit of a concern to kind of step back a little bit. But if you're just dealing with that pain, it also involves kind of looking at that individual's understanding and their pain perception, right? Is it a soreness or a stiffness, or is it a true actual sharp pain that's occurring? And then you start throwing in, that component of fear, right? Which kind of drives a lot of individuals' activity.
Yeah, I do find that kinesiophobia in a sense, or, kind of the fear cycle, then it promotes less exercise promotes, kind of worsening of the disease process or decreased functional abilities. And then it kind of propagates the cycle in a sense. And we see that a lot from a pain standpoint. And it's almost counterintuitive, I think, for probably a lot of people, listening to this webinar, that sometimes movement is the best medicine in that sense, specifically for joint disease. And, to Dr. Thompson's point, the cartilage degeneration and the joint disease is not being made worse by the movement in that sense. And so I think that's important for people to understand. So here's another question that's coming through, and it says, why is my pain worse when I go to bed at night? Dr. Thompson, any thoughts on worsening pain at night in bed?
Yeah, well, I think, a lot of that depends on kind of what you were doing that day. And there may be more, not necessarily even joint pain, because a lot of the times joint pain is actually worse in the morning when you're stiff. And that's a different type of pain. At night, a lot of the times it's more muscular pain. So if you, exercised a lot, or if you really kind of wore yourself out, and just in general, if you're tired or you have other stressors, sometimes we do feel pain, or it localizes more to our joints or our muscles. So a lot of that can be that. And it's not necessarily pathologic. It's just that you've kind of worn yourself out the way that you wear out your kind of mental capacity, you wear out your joints capacity throughout the day, when you're really pushing yourself. And as long as it resolves by the morning, nothing terrible is happening. It's just kind of the natural cycle of kind of pain and the arthritis that you're feeling.
And I think that's important too, is knowing that it's not always just the joint. There are other things that can be causing pain, whether it's in a hip, a knee, an ankle, all of the above. And so, working with your healthcare professional, whether it's your therapist or your physician or your surgeon or whoever, to kind of figure out, well, is this actually what my pain is? Because you're right, it may not be from a joint, it may be from a muscle. Now, Dr. Weiner, when patients have pain at night, do you have any recommendations for sleeping positions and whatnot? And again, I know that's very patient and case specific.
Right. I think so. Yeah. In that particular case, I want to know more again about the routine of the patient and a little bit more context. But generally, the least stressful position to the body when you're sleeping is in side lying and supported. And I think that part of that question too, I think the individual said that they felt better when they were on their feet, that something about the pressure. So there's something about that support to the body. And so if we can kind of create that alignment, be more in neutral posture, it happens easier on your side with a pillow between the knees. Again, so you don't have that internal rotation of the hip. And then even a pillow between the arms, so your shoulders are more neutral. So you can try that. maybe some additional support pillows at the feet if you're experiencing some ankle discomfort. And of course, we might shift and move over the course of the night, but it's a good way to start off, especially if you're experiencing that pain at bedtime.
That's good advice. I may have to adopt some of that as well. I might need a few more pillows, it sounds like.
You know, a pregnancy pillow, it wraps all the way around the body. If you've seen that,
right.
I have recommended that for my back patients before.
Well aware of that in my current state.
I figured as much.
Dr. Berner, any thoughts on pain at night with sleeping, or potentially any sort of exercises to do before bed, when you get up, you know, things like that?
Yeah, so I'm actually going to piggyback off of what Dr. Thompson had said. You know, it really depends kind of how your day looked in its entirety. And at the end of the day, you know, what is your body's, and the term is allostatic load, you know, how hot was your engine running? Because if we look out the, you know, if we look at arthritis and we look at pain, there's an underlying factor of
We've either lost him or he's deep in thought. So I'll go ahead and move on to the next question, and then we can get him back when he gets his thoughts together. So the question is, going to you, Dr. Thompson, what can and can't I do physically after hip or knee replacement? So precautions when it comes to joint replacement. And I know that, again, this is patient and case specific, but some generalities.
Yeah. So, you know, I think in general, if we break it down to knees and hips, and then hips, there's a couple of caveats. For the knees, there's very little that you can't do. Typically, in a typical primary total knee replacement, they're pretty stable. Now, knees are harder to recover from in general than hip replacements. So you're not going to want to do much immediately afterwards. But once you get cleared after those first 6 to 8 weeks, depending on what your surgeon tells you, you're able to get back to all of your activities. That includes hiking, squats, yoga. There's no real limitations. And the most important part is getting back to, again, those functional activities that we've, talked about, and working with your therapist, your, physical or occupational therapist, about finding ways that you can work around some of that stiffness until you get that mobility back. As far as the hip replacements, immediately afterwards, if your hip is put in from the back, a posterior approach, so if your incision is kind of along your bum, those are the ones that you have precautions. So you cannot flex past 90, so past a sitting. So sitting on a low toilet is a no-no, or any low stool. Crossing your legs past midline. So, for any type of cross sitting, or internal rotation. So if you're sitting down, bringing your foot towards the outside. That's for the first 6 to 8 weeks. Hips that are put in from the front, so if your incision is in the front, you don't have those precautions. But again, even after 6 to 8 weeks, no matter how your hip is put in, as long as your surgeon gives you the go-ahead, there's really no limitations as far as range of motion for the long run for a total hip or a total knee, if it's a primary hip or knee and there's no, extenuating circumstances.
Those are good tips there. Now, Dr. Berner, we are talking about exercises and precautions after total joint replacements. And I'm going to ping this over to Dr. Weiner to see if she has any other ergonomic tips for post-arthroplasty or post-joint replacement.
Sure, absolutely. And I did work 10 years in inpatient rehabilitation with post-surgical. And so I understand, with the knee, the biggest limitation you'll have is that range of motion when you come out of surgery. And so it will be very hard to get down on a regular size height toilet and on and off furniture that is low. And that is really the main limitation. So it's learning the body mechanics, for example, to kind of put your heel down on the ground before you stand up and sit down, as opposed to letting your knee kind of naturally bend as it would, because that just won't feel very good post-surgical. And then with the hips, as Dr. Thompson mentioned, the potential posterior precautions, in that case, you would go home with what we call a hip kit that would really help you with your daily activities: a long-handled sponge, a long-handled shoehorn, a reacher, and they're really just fantastic tools, so you don't have to count on somebody else to help you with your self-care. It's just refashioning the way you do your daily activities.
Excellent. And Dr. Berner, do you have any thoughts about any kind of exercises and things after a total joint replacement?
Yeah, so sorry about that, Dr. Vincent. The hotel internet is not as reliable as you would think. So
every time.
Yeah. Exercise specific, right? It kind of comes back. And for me, I always go towards trying to train those functional movements because that's what people are going to be going back to, right? When they get back to their day to day. So it's kind of, again, modifying those activities and gradually working through that available range and loading it appropriately to what the patient can tolerate, but then also as far as what's tolerable after that procedure.
Yeah, and I think those are all really, really good tips and advice for post arthroplasty. But to kind of the overarching theme is work within your limitations and work on your range of motion, and then slowly start to progress back and beyond. Hopefully, now that one of your main sources of pain is eliminated. So as I'm looking through some of the questions here, I see a lot of comments and questions about bone on bone or severe arthritis or bone spurs. And I want to open it up a little bit, and I'll start with you, Dr. Thompson, but talking a little bit about the concept of bone on bone arthritis. And, we see this all the time and we hear it all the time. And elaborating on bone and the need for surgery and functional limitations and how there's kind of a bit of a misnomer there.
Right.
Sometimes.
So I think this is a great question because we hear this a lot, that I have bone on bone arthritis, and it sounds like it's like, oh my gosh, there's bone on bone. What it like, but no one really knows what that means, right? But essentially what it is that on X-ray, if someone's told you, oh my gosh, it's bone on bone, it's that cartilage that lines the end of the bones that kind of are a joint together. So in a knee, a femur, and a tibia, that cartilage has worn down so that we no longer see that cartilage shadow on the X-ray. So the bones now don't have that cushion in between, and they're bone on bone, they're touching each other. That being said, we don't really treat X-rays. So even if your X-ray looks awful and you don't have any really cartilage space and it looks like your arthritis is really severe, but you're doing okay, you're functional, your pain is well controlled, you're able to do all the things that you like to do, it doesn't necessarily mean that, oh my gosh, you need surgery because someone said you had bone on bone. And on the corollary, some people don't have bone on bone arthritis. They have, some of those bone spurs, some of those changes, but they're really limited no matter what they've done, no matter how they've worked on with, medication management or injections or with their therapist, they're still limited to things that they aren't able to do everything that they want to do to enjoy life. And then you're indicated for a joint replacement. So it's really different for each patient. And the X-ray finding in and of itself is certainly consistent with severe arthritis, but we really should focus more, and you should focus more certainly on how you're feeling, not really necessarily what the X-rays are showing us.
Yeah, the concept of, don't judge a book by its cover kind of thing. We don't judge a patient by their pictures, their X-rays, and it's how you're doing and how much it's affecting your life. I'm sure every one of us here has seen somebody with bone on bone that's out there, as a high level athlete, in their older age, in a sense, right? Dr. Berner, how many patients have you done exercises and therapy and all of the above with that have bone on bone?
I would say probably anybody and everybody that's got some type of X-ray result. That's typically what they say, right? If they've had the X-ray done, that's the information that they're coming to me with is that they're bone on bone.
Yeah.
So a lot, right? And from a pain management standpoint, it's the same, right? And I feel like this education process, this discussion here happens every day, and it's important for people to understand that, right? And it's hard for people to understand that because they say this is going on inside my body, and it's really severe, and it must be, an end all be all. But I think it's important for everyone listening right now to understand that that's not necessarily the case. And there are ways that you can work around that and thrive and be active and live a fully healthy and functioning life, even with bone on bone or severe arthritis. But that's why you work with your PT, your OT, your surgeon, and your pain physician to get it all figured out. Okay. So moving down the list here as they're rolling through. So here's a little bit of a different one. And I'm going to ping this back to you, Dr. Berner, and then we can send it over to you after, Dr. Weiner. But the question is IT band syndrome related to joint problems? In addition to a foam roller, what can you do to avoid or relieve it? So, Dr. Berner, why don't we start with you? There you go. Yeah, so that's always a hard question, and I'm sure my fellow panelists and yourself can agree. There's only so much I think you can do specifically for an IT band. You know, I kind of remember back to PT school looking at cadavers, and it's kind of reminds me of a seatbelt in a car, right? The thickness of it, and kind of how it's placed in the body. It sometimes is very difficult to really do anything specifically to what is termed to be, the IT band, right? So for me, I kind of always think the IT band syndrome to somewhat be of a catch-all. So it's up to us, as the PT, the OT, other rehab professionals, and your surgeon in some instances to find out what is actually causing what is being termed the IT band, right? Because it's most likely not that band of fascia. It's likely something else.
It's a good point. And Dr. Weiner, any thoughts on that as well?
I'm not sure I have much of an elaboration. I definitely agree with Dr. Berner, but I think it comes down to no matter what the condition is or no matter what the diagnosis is, it's that tuning into those early cues of discomfort when you're specifically during the day throughout your activities, changing positions, finding those comfortable positions and integrating more movement into the day, all of the things that we've discussed so far. I think that we can apply those to multiple different conditions, same strategies.
Absolutely. And to both of your points, I think a lot of times the IT band may or may not be the issue, right? As you said, Dr. Berner, and could be the lateral joint line there. You have other ligaments that are there. There's the tendon itself. So one, identifying the proper structure, I think, is super huge for really treating the pain. And then, taking a step back and saying, well, how did this start and why is it continuing to be a problem? Is there something from a biomechanical or a muscle activation standpoint that's causing forces to be put through the joint or through the tendon in a different way, right? I think going back to the basics, and whether that's working on ergonomics or therapy or, whatever it is, I think that stuff is really important to take into account before you start doing injections and things like that, which may or may not provide benefit more than, changing the activity or the activation and things like that. So again, the IT band is a tough one, certainly. That's for sure. Okay, so let's see here. Okay, here's a good one. And I'll start with you, Dr. Thompson, but we get a lot of questions about supplements for joint pain. Do you have any non-pain medication or more, I would say, supplements that you recommend for joint pain? And how do you kind of approach that with patients?
As far as oral supplements or injections?
Yeah, oral supplements.
Oral. So, it's tough. There's no great evidence anyway that there are any supplements that really make any significant difference. And when I mean significant difference, I'm talking again about any real improvement in the cartilage. So if you, looked at the cartilage with an arthroscope, right, went in there surgically, looked at it, and then gave someone tons of supplements, even for a year, you'd really not see an improvement with any of those, or looked at an MRI, you wouldn't see an improvement with any type of supplement. That being said, some patients swear by certain supplements and say, okay, when I'm taking my chondroitin, I feel so much better. And to me, it's the same thing, certainly like acupuncture. I don't have great evidence that acupuncture is going to change the cartilage disease, but if it makes you feel better and it allows you to get through your day and it makes you be more active, well, then by all means, take the supplements that work for you. The one caveat with that is there are certain supplements that you want to make sure if you are going to move forward with a joint replacement, that those supplements need to be part of your medication list so that the anesthesiologist and us as surgeons can say, okay, these ones are not necessarily good with the medications we're going to be giving you postoperatively. So you have to count them as medications that you're taking every day. That's the one caveat.
And I think that's good as well, because everything that you put into your body may or may not have side effects, right? And so, if you're taking a medication that you want to try to help treat your joint pain, but it's giving you significant nausea and vomiting, well, then that risk to benefit ratio may be not so good, right? But let's ping this over to Dr. Berner and see what his thoughts are.
Yeah, so for me, kind of putting on, my other professional hat as a registered dietitian, my first and foremost thing is always trying to influence what people are eating, right? So trying to look at their eating pattern, right, what they're consuming day to day and on average, and making sure that they're getting the nutrients that they need, and making sure that they're consuming more of that anti-inflammatory pattern, right, to really facilitate, right, good recovery within the body, but also, reducing any of that systemic inflammation that's going on that could be potentially contributing to, the pathology of that arthritis or that, that presence of pain. So for me, it's getting people to eat better, always first and foremost before any kind of supplement.
And I think that, addressing that through food is certainly the best first line option. It's most certainly the most difficult, right? Because it's an ongoing pattern and behavior that I think takes effort, and that's oftentimes difficult for patients, certainly. When I try to address supplements with patients, it's oftentimes actually kind of a combination between both of what you said. And I think dealing with things from a systemic standpoint, especially, in the cases of rheumatological disorders like rheumatoid arthritis, that overall systemic inflammation can be really important. Some of the research, and again, it's not great high quality research, but some of it shows that omega-3s can have a potential positive benefit. Now, whether that's from food or oral supplementation, there's been decreased pain reports in patients with RA and joint disease. That being said, the research is growing and not significantly strong, but there are some research studies devoted to that. So let's pivot a little bit. We're going to go back to ergonomics, which means we're going to go back to our ergonomics expert. All right, and that's Dr. Weiner. So it says, tips for buying an ergonomic chair for hip pain and back pain. Thoughts on footrests for work?
Great,
Ready,
great
set,
question.
go.
Yeah, so we want to look for some key features in our chairs, and each of us are unique. Our size and our stature comes into play here. So you need to kind of maybe take a few measurements and kind of examine yourself as you think about this. But an office chair should have, number one, height adjustability. So you should be able to sit so that your thighs kind of have a downward slope, meaning that your hips are slightly higher than your knees. And that's going to promote better circulation down to the legs. So you want to make sure that the seat height is sufficient so that you're able to sit hips higher than the knees slightly. Now, this brings in the footrest. The answer there is it depends. If you're more petite, and once you've achieved that position where the hips are higher than the knees and your desk is at your resting elbow level, if your feet are not supported on the ground, at that point, you would be a candidate for a footrest. And a footrest, again, you want it to be kind of low enough so that your knee doesn't become higher than the hips, okay? So the footrest is I tend to think of it as for somebody who is maybe 5'5" or shorter, we tend to enter that territory there. The other features of the chair you want to think about is the seat pan depth, and make sure that you can sit all the way back with your back supported while having a little space at the back of the knees. So when we have the front of the chair pressing the back of our knees, that's contact stress. So we're interfering with the circulation again at the back of the knee, which is where a lot of blood flow takes place. So you're looking at seat height, seat depth. I'm going to make sure the chair has good lumbar support. And armrests, if you have them, make sure that they're adjustable. Best advice here is if you're going to buy online, look for something with a trial period, free returns, that has all those adjustments to make sure it's a good fit, because this is something that we spend a lot of time in. It's kind of like a car or even a mattress. So you want to make sure that you feel comfortable in your chair. Or if you have that opportunity to go to a local showroom and sit in some chairs, and even assist somebody to help fit you to an office chair is a really effective way to make sure that you get the right chair for you.
Now, how has, I guess, on a personal and professional level, how has COVID affected this? And, with you working with patients from an ergonomic standpoint, how have you seen it change?
Yeah, so we are doing a lot of makeshift things to make this work around the house, especially initially, and we can do that better with attention to neutral posture and ergonomics. But chances are we don't have that adjustable office chair. We're working from the dining table. We're working off laptops, which is causing a lot of neck discomfort. So again, if we focus back on the idea of neutral posture and do things like If you're sitting at the dining table, sit on something that will raise you up higher so you get that downward slope. Use a rolled towel to put at the back rather than just sitting in a straight back chair. So we can be crafty, but we also want to think about, is this the future of my job? Then I should really invest in some equipment that fits me, making sure I'm not using that laptop all day long at the dining room table.
I'm pretty sure I personally broke every single one of the rules that you just said. So I'm going to either need a formal consult or I'm going to need to return all the chairs that I bought off Amazon.
We can talk.
During COVID. Okay, great. Okay, so here's a question that just came through, and it's simply titled Thoughts on PRP Injections, right? So for people out there that don't know what PRP is, PRP stands for platelet-rich plasma. This is a concentration of components of your blood that are commonly used as an injection into joints in an effort to decrease pain and stiffness and the symptoms of arthritis. Now, PRP is most certainly not well researched currently, but it is commonly used. I would say that the use definitely outweighs the research at the current moment, and it is certainly not for everyone and not for every joint. However, in some patients, it can be beneficial with improving the symptoms of whether stiffness and pain and helping with functional improvements. It will not help regrow cartilage, and it will not necessarily prevent you from getting a joint surgery down the line, but it can help with some of the symptoms that are associated with arthritis. Now, I will ping this over to Dr. Thompson to hear her thoughts on PRP.
So my thoughts are pretty similar. There's been kind of a craze with using PRP for everything: plantar fasciitis, tennis elbow, any type of joint pain, rotator cuffs. I mean, you can come up with a problem and someone will offer you PRP as the solution. That being said, there's more evidence now, certainly coming out with some meta-analyses, so really pooling smaller studies together that do show a bit more efficacy as far as pain control and symptom relief with PRP versus other type of injections like corticosteroids or Synvisc, which are other injections that a lot of people use for arthritic pain. And it's no less safe than either of those injections, which are, have much more long-standing research. But again, it's not going to kind of reverse the arthritic changes. And it works in some patients, and in some patients, it really doesn't do anything. And with all of these injections, they don't come without risks. Anytime you have an injection, there's a risk of infection. And it's very small risk, but it's not zero, certainly. So you have to be, trust the provider that's going to offer it to you. And it is an option as like an adjuvant or something extra for pain relief.
I think those are definitely good things to take into consideration when you're considering going down that injection road, right? Because if you think about, there are many people out there that will also offer, steroid injections into the joint, and steroid injections, we know can cause more systemic effects. We also know they can have some potential detrimental effects to the cartilage and can cause thinning over time as well. So things to consider when going down the line for any of the injections. Now, a lot of times there are other injections that, like you said, the hyaluronic acid or Synvisc, and we've had a lot of questions about that as well. That certainly is an option for patients. It's another form of an injectable that goes into the joint. It's called hyaluronic acid, and there's about 25 or 30 different variations of that. Essentially, if you want to think about it as a lubricant to the joint, almost like a WD-40 or a gel type solution. Some of the research shows that PRP may be a little bit better for providing long-term relief, but at the same time, sometimes it works for patients, sometimes it doesn't, right? And it certainly is not going to cause, regrowth of cartilage or potentially, delay your need for surgery. So again, these are options that are out there. They carry risks, certainly. They are procedures, and they're not necessarily right or wrong for each individual. That's why you have to take it on a case-by-case basis. So we'll leave it at that as far as the injections, but I think that's decent words of wisdom from Dr. Thompson there. So another question that came through is about the benefits of PT versus OT versus chiropractic care for pain relief. So not to create an internal battle amongst our panelists about whether who's better, PT or OT, but we'll start with the OT and then we'll let the PT respond in rebuttal. Dr. Weiner, thoughts?
We are a team. PT and OT work together. We complement each other, and it's a beautiful thing when it comes together like that. So I say both. You know, the OT will not teach you specific exercises, but we will teach you exercises to help with the job of daily living, to help you negotiate and problem solve and use tools, and start with the function, the task first. Whereas PT obviously takes a different approach, but we meet in the middle. And that is, we have the same goals, the same outcomes, and that is function.
Dr. Berner?
Yeah, I don't know that I can rebuttal that. I mean, that was well put. It's a team effort.
You guys are too friendly. I wanted a fiery battle where, you know, OT is the enemy and PT doesn't know what they're talking about.
Yeah, I mean, we're working towards the same goal. So I think what Dr. Weiner said, right, they're kind of starting at that task, right, kind of that activity, and working, and in a sense, working backwards, where for PT, sometimes we're working and looking at the body first, right, and trying to build it up towards that task. So I think in some cases, we're just maybe starting at different ends of the spectrum, but ultimately we're coming towards the same goal. So it's nice when we have that team approach.
I like it. I think everyone here agrees. More the merrier. Okay, so we're getting a few questions coming in here about low back pain. All right, and so I'm gonna ping this back to you, Dr. Berner. But are there a couple exercises that you like for, let's call it, axial low back pain? And then I'm going to ping this back over to Dr. Weiner to talk about some of the ergonomics that you can potentially do throughout the day. Okay, so when someone comes in with axial low back pain, you know, what are some of the, I guess, the basic exercises that you like for patients?
Yeah, so it's always kind of meeting them where they're at, kind of seeing, you know, their tolerance of load and being able to gradually increase that load. So traditionally kind of starting out with just general body movements, right? So some flexion, extension, you can roll into, you know, your traditional bird dogs, things like that, to kind of challenge the core musculature while also challenging the back. But it's really going back into those functional movements and being able to load the body so that, you know, they can tolerate, and that the spine can tolerate those loads. So, I mean, to me, it always goes back to, you've got to be able to deadlift and squat, right? You've got to be able to get on and off the ground. There's functional movement that you have to be able to do. So it's meeting that person where they're at, and kind of seeing what their tolerance is to activity, and then just progressively increasing that load from there.
And getting back to those foundational movements, if you want to call them those.
Yeah, getting back to the foundations. Yeah.
How long, again, very general, but how long does it take for patients to get back to that foundational support that you find from a movement standpoint?
And I've been dealing with these type of questions all week, and working with PT students, right? It's always, it depends, because you start adding in all of the other contextual factors of that individual in front of you. You know, do they have a fear of pain? Do they have anxiety over activities? You know, is there a big chunk of pain science that needs to be addressed? You know, you have to look at all of those other contextual factors with that individual. So it's hard to give a timeline. You know, my hope is that we're significantly better, you know, within 3 to 4 weeks. And as a practitioner that practices direct access, right, within my state, my goal is to get somebody back at a significantly better level of function within 30 days. Otherwise, you know, I'm obligated to refer to another provider to kind of start looking at things as well.
I think that's a good timeline, though, for people to know that that is possible, right? With the proper guidance, and you know, you can do that safely, and you can progress back, you know, in that 3 to 4 week time period. And Dr. Weiner, any other thoughts, you know, from an ergonomic standpoint with axial or non-radiating low back pain?
Yes, and it's one of the number one discomforts that my clients have is back pain. And I'm going to offer 2 tips here. So we tend to get stuck on a bit of a myth with ergonomics. It has to do with sitting up straight. And when we are sitting up straight, I think about unsupported sitting, where we're engaging a lot of the muscles in our core and back, and it just doesn't last. Force of gravity, computer workstation, we end up slumping, and we usually don't stay like this. So what we want to do is have support. So it's important that your workstation, the chair that you work at, has good back support. And then you'll be able to stay neutral, supported, and relaxed, actually. And so that's a biggie. You can definitely put those principles into action no matter where you're sitting, so to speak, is to make sure you have some good back support. And then the other piece specifically for back pain is change of position. So many people have gotten into the sit, stand, desk trend for this reason. It certainly can help people with back pain to change a position, but the value isn't in the standing, it's not in the sitting, it's in the change and the opportunity to change. And it's okay if we don't have a sit, stand, desk, as long as we're getting up out of the chair every 30 to 45 minutes for about a minute at a time. So that can really go a long way. The next position is the best position is the next position. It's something many of us have probably heard before. Sometimes the standing desk helps with that, but again, not a necessity when it comes to ergonomics.
Excellent. I like that. Okay, so now switching gears to a little less common area of arthritis, but one that can be significantly debilitating nonetheless, and that has to do with big toe or foot arthritis. And we see this a lot, and it can definitely be painful. And not to mention, there can also be other pain sources around that can be exacerbated by arthritis. Dr. Thompson, I'll start with you from a surgical standpoint. Can you give some insight as to, big toe arthritis and fusions or other surgical options and what their success is?
Right. So the good thing about big toe arthritis is that all of our surgical options, unlike some other joints, are all really good options. So they all have really good track records, and patients really respond well. That being said, it's still a joint that could, benefit from differences, in shoe wear, differences in activities. Injections sometimes help before you get to the point where you are looking for a surgical option. But your two main options that most of us use now are either a fusion of that big toe, which is actually really functional, responds really well, gets rid of the pain. You have a little less motion, obviously, right at that big toe knuckle. But long-term outcomes are that patients really do well. You can still run even if you don't have that joint, or doing a silastic arthroplasty. So it's replacing that joint with kind of a silicone material, and patients do really well with that as well. It's a bit less definitive, but you maintain that range of motion. And always, if you have any problems with that, the bailout really is to just go to fusion, which is another good, still a good option. Even if there's any problems, that if you have continuing pain or the implant doesn't sit appropriately. So I think the good thing about toe arthritis is you kind of can't go wrong once you get to the point if you do need surgery.
That's good to know. And it's always nice to have a surgery that works.
Yeah,
Which
right?
is good. That's right. Now, Dr. Berner, when someone comes to you and has foot arthritis, foot and ankle, big toe arthritis, what kind of things are you looking for? And again, obviously working within their limitations, but what are you looking for and how do you approach that?
Yeah, so it definitely starts with kind of looking at the footwear that they're using, kind of the time, the wear time they have with that particular footwear. But then, not just that footwear that they've got on at that time, but also kind of having that conversation to see, are they changing footwear frequently throughout the day? Are they wearing footwear for, while they're at work versus when they're at home? And kind of really trying to understand, where is that foot most of the day? Are they sitting? Are they standing? And looking again, is that footwear going to be appropriate for them? And then when you start getting down the road in severity, right, needing something specialized, I usually reach out to a local orthotist to kind of help, really trying to fine tune something. I'm not really keen on using something off the shelf when it comes to that, because we're all different shapes and sizes. And I find sometimes it's difficult to address that individual with kind of using something that, again, that's off the shelf. But it's always going to start with that conversation to see where that person is and what could potentially be irritating that condition.
Certainly. And Dr. Weiner, in regards to specifically big toe arthritis, is there any sort of orthotic or insole or shoe or anything that you use in that sense?
You know, that is really not my area of expertise. I'm going to defer to Dr. Berner for that one. I would say that when it comes to the workstation and work habits, it's paying attention to whether, you know, obviously taking the weight off by sitting, you're distributing less of your body weight through your foot when you're sitting, but it's important that you still do have your feet resting on the ground. And so they're not just kind of underneath you or a bit crossed or that type of thing. So it's finding that kind of gently supported position is probably going to be the comfortable position when it comes to seated work. But I big toe, not my area of expertise.
Perfect. No problem there. I think one of the benefits of the Zoom revolution is that you can always take your shoes off, right? There's probably at least 500 people on this Zoom webinar that do not have shoes on, I would guarantee it.
I don't.
I have one on. I don't know if that's good or bad.
Excellent.
Okay, so going back to some of the surgical options here, this is actually a really good question and more of an overarching concept, but it says, how many opinions should you get if one surgeon says you need a knee replacement and the other one says you don't, or one says, you know, you need a partial and one says you need a total? Can you talk a little bit, Dr. Thompson, about surgical recommendations in that sense?
So, you know, it's tough when you get two very different opinions. I think there's a few guiding principles. I go back to one of my mentors always used to say to his patients, and I say it to my patients all the time, come to me when you're sick and tired of being sick and tired. So there's no perfect time to get a hip replacement, a knee replacement, you know, a toe fusion. Everyone is different, and it's not based on your x-rays. It's really based on your functionality and what your goals are. And so if you've kind of reached your limit with non-operative management and you still can't live the life that you want to live, and for you, maybe that's hiking, maybe for someone else, it's being able to just walk around the block. So if you can't meet those goals without surgery and you've kind of tried everything else, then I think that's the time that you need surgery, and that's when surgery is appropriate. And then as far as getting two different opinions, you know, I think if you're getting two really disparate opinions, you know, you have to advocate for yourself, and you're not, you know, being, you know, crazy by getting a third opinion, a tiebreaker, if you will. And I think it's important if you're going to that tiebreaker to say, hey, I have these two opinions. Which one do you think is right? Especially now, because we can do a lot of things with telemedicine. It's, you know, even for new patient appointments, you could do that via telemedicine and kind of quote unquote shop around. If two surgeons are giving you pretty similar opinions, really, I tell everyone, go with whoever makes you feel comfortable. So as long as, you know, they're both kind of board certified orthopedic surgeons, you know, it's whoever you feel most comfortable with, because you have to have a relationship with this person even after the surgery.
And I think that was going to be my next question, is how do you guide patients to choosing the right surgeon, right? And I think, you know, patient comfort and having a certain level of rapport is extremely important, right? Because once you undergo a procedure or a surgery, you're going to maintain that relationship for quite a while. And right. So that's really important.
And I think if the surgeon that you're going to is not giving you the time of day preoperatively, they 100% will not give you the time of day postoperatively. So it is important to find someone, you know, that it doesn't just see themselves as a technician, but really sees themselves as part of that care team with your physiatrist, your primary care doctor, your physical therapist, your occupational therapist, not someone that's just going to come and, you know, do their surgery and be done with it. So you want someone that's available for you preoperatively, because it kind of will reflect how available they're going to be for you postoperatively.
Certainly. And I think also, to that point, you know, surgeries can have various outcomes. And if for some reason the surgery is not as successful as you want to know that surgeon or your care team is going to work with you to find an option to either fix it or help make something better or change and go a different direction. You know, there's that certain amount of care pivoting that is necessary sometimes. And so that's one of the other questions is how can I tell if my joint replacement failed?
So, I mean, there's kind of the word fail for a joint replacement is really kind of like a loaded word, right? So there's kind of these catastrophic failures where, if a hip is dislocated, that's a failure. And you'll know that when you have these big catastrophic problems, when a hip is fully dislocated, or, certainly if you have an infection where you have a fever and you can't move that joint. And then there are these smaller things that you might consider not 100% where you want to be from the joint replacement. So maybe you're not getting as much range of motion as you want. Maybe you're still having some pain or some limitations. And so I think it's, again, giving it time, taking a step back, really working with your therapist postoperatively, making sure that you are optimizing everything, and giving time to get that range of motion back, get that strength back. And then, certainly going to your surgeon. Part of it is getting x-rays if there's any concern for an infection, getting labs. But you kind of always have to take a step back too and realize a lot of your pain is going to be gone pretty quickly, but getting that function is going to take a while. And that doesn't mean that you're a failure or your surgery is a failure.
All good points, definitely. And Dr. Berner, from if we'll call it a failed surgery, right? If we're calling it a failed surgery, do you see patients that have had knee replacements that are still having pain, and how do you address those from a therapeutic standpoint?
Yeah, so I have, and it's definitely challenging because you typically take that patient, right, who's been dealing with that pain and they had the surgery, which, the hopes were that it was going to totally alleviate those symptoms. And at that incident, it becomes frustrating for that patient, right, that they're having to deal with that they thought that things were going to get better, and they're not. So for those patients that I've had to deal with that, it does come kind of implementing some more pain science and conversation and looking at kind of that fear of movement and really fear of pain, and trying to see if there is another component that could potentially be aiding to those symptoms. And that's a conversation with the ortho too. And I don't know if it's actually ever true, failed surgery, or if it's actually components that are not, working appropriately. I think at some point there is a bit of a psyche component, that there is that possibility. So it is being able to have that conversation. And for some clinicians, other therapists, they may not be comfortable with having that conversation. So, it is important to know that there are other providers, and I'm sure like yourself, Dr. Vincent, that specialize in having those conversations.
I 100% agree that the psychological and the mental component with it, right, is huge. And a lot of that, I think, as docs and practitioners, is sitting down and taking a step back and understanding that this is a spectrum and this is a journey. And our journey and our part of it, in my opinion, is here, but their journey has been here. And there's been so much that's led up until they got to our care. And sometimes I think, helping the patient understand that we're here, this is where you were, this is where we are, and this is where we want to go. And it's going to take all of us, even on this call, or whoever your care team, to get there. I think that understanding that is sometimes difficult for all of us, in my opinion. Okay, to lighten it up a little bit, this is going back to you, Dr. Weiner. I'm actually not sure what this is, but on the wall chair.
Okay. If this is what I think it is, it's it's like a leaning chair, basically. So it's a tall chair that has like a ball looking thing on top, and you can move on it. And it's typically used with a standing desk. So a wobble chair is one way to change a position. It can be used as a strategy throughout the day. It's not an all day long 8-hour workday chair. So I think about this, the advantage of the wobble chair is you combine the kind of standing, you combo standing, seated with back support, and then wobble chair where your hips are much higher than your knees. You have a nice wide open angle of the hips. You're still putting weight through the feet. And this can be a very comfortable position to go into in an alternate position, most importantly. It's different than what you are at the chair. It's different than what you are at standing. And that's the value. But it's not an all day long work chair. So I would encourage anybody who has one of those to use those as tolerated intermittently throughout the day for a change of position. And that is how it will benefit you the most.
So we need two chairs. You need a wobble chair and you need your ergonomic friend.
If you're going to pick one, it's going to be the regular chair, and you want to make sure that if you have a wobble chair that it's height adjustable or your desk is height adjustable, because then you get into the position of, one height desk, one height chair, you're just reaching up or doing something to compensate, in other words. So adjustability is key.
Got it. Okay. And so kind of in that same vein, of low back pain, right? There's a question here, how can I tell if my back pain is causing hip pain or hip pain is causing low back pain? And I'm sure we all have kind of seen this in various forms, the hip low back conundrum. From a functional or biomechanical standpoint, Dr. Berner, how do you kind of see that relationship, and which one's the egg, which one's the chicken kind of thing?
Yeah, so it's really just kind of putting that patient through a full examination and kind of assessing what could potentially be causing it. And it's always typically a test retest, right? That's pretty much what most of my job is test retest. Is what we're doing working? Is it making successful change, or do we need to alter? So it's hard to determine, is it chicken or the egg? It's trying to find out for that individual specifically what's going on. Yeah, it's hard to say. It's really what we deal with all the time.
It's very patient specific. There's no question about it. I think one of the things that I do see frequently is, if someone does have joint arthritis and that causes some sort of a gait abnormality where they're now walking differently, you can see exacerbations of pain either in the low back, right? Or you can see the tendon get flared up on the other side. So as they're kind of having that painful or antalgic gait, can you get some sort of gluteal tendinopathy or trochanteric bursitis on the opposite side? And a lot of times, that's a new injury, so to speak, as a result of joint disease or low back pain and whatnot. So I will see that quite often, where it's not necessarily that you now have arthritis on the other side, but it's actually the tendon or the bursa that's inflamed. So new problem, more of an acute problem, not necessarily a new chronic problem. And so some things that I kind of try to navigate around. Dr. Thompson, any other thoughts on that?
No, I think, the only tool that we use, because we cheat, is getting x-rays, really. If you're if it is a confusion, sometimes x-rays or imaging can really kind of hone in on, is there arthritis in the low back? Is there arthritis in the hips? Now, it's not going to tell us anything that either of you had touched upon as far as kind of muscle pain, but it might get towards the etiology and might kind of help us guide, if we know exactly where the pain is coming from a bony or a joint standpoint, kind of where to focus our efforts.
We do get to cheat with the imaging, that's for sure. Sometimes a picture is good. Sometimes.
Right, yeah.
So there's a question that came through about thoughts on radiofrequency ablation for arthritis. So I'll take that for the lumbar spine. Now, radiofrequency ablation is a fancy term for burning nerves that innervate joints in the back. So as your spine sits on top of each other, there are joints that articulate in the back of the spine, and they are innervated by a very specific nerve called the medial branch. Now, a radiofrequency ablation uses needles to go down to those nerves and essentially ablate them or kill them. And by doing that, it decreases the sensation of pain in those joints, typically the lower joints in the spine. So a radiofrequency ablation can be appropriate for patients that have what we call axial low back pain, or pain that's confined to the low back, not radiating down the legs, not caused by a disc, but caused by the joints in the back, right? So that's axial back pain. Typically, the way that this procedure works for patients is they have to undergo 2 diagnostic tests. They really want to make sure that this is the area that's causing your pain, because low back pain is very multifactorial and it can be often very hard to diagnose where exactly the problem is. So this is specifically targeting the joints in the back. So they want you to undergo 2 diagnostic procedures where we go down and we take a little bit of numbing medication to temporarily block that pain. If your pain gets better and significantly better for about 4 hours, we know that that's the right spot. We bring you back in and we go down with a different type of needle or a probe, and we ablate those nerves with typically heat. Now, most of the time, if it's a successful procedure, you can hope to get about 6 to 10 months of relief for your axial low back symptoms. Okay, so I think that would be optimistic, and that's if that is your pain generator. Again, low back pain is multifactorial, so something to take into effect that it may be more than one thing causing your back pain, but it can be successful in low back situations. So good question, whoever had that out there. Radio frequency is a good option for axial low back pain. Okay. Dr. Berner, quick question. Do you see patients that are getting radio frequency ablations? And how do you, if so, how do you kind of tackle the rehab after that?
So I don't. Yeah, I've honestly not had one that's had that.
Yeah, so a lot of times, when a patient has a radio frequency ablation and they're in a pain-free interval of 6 to 10 months, ideally, I say, all right, this is your time to really go after your physical therapy, really focus on your core strength, really focus on Pilates and getting the deeper intrinsic muscles surrounding the spine strong. Because oftentimes, as we've discussed, the fear of movement and the fear of causing pain causes people to not do those activities. And that's further worsening the problem. And so if we do a radio frequency ablation, I'll say, all right, go to your therapist, and it's time to hit it hard for the next 6 months, with the hope that now they, gain that internal corset and we do not need to do more ablations in that sense. But things to think about. Okay, so we are getting more and more questions about ankle arthritis. So we're moving up from the big toe to the ankle. This is a complicated joint. I will start with Dr. Berner, and you can kind of discuss a little bit about how you approach ankle arthritis from a biomechanical standpoint.
Yeah, so it's always going to start, again, looking at that footwear, okay, because you're just kind of going up the chain, really. So it's looking at the foot coming into the ankle. So first looking at that footwear, but then looking at the biomechanics of the knee, biomechanics of the hip, and even if that person's dealing with any low back pain, right? Things are going to go up and down the kinetic chain. So it's trying to determine, typically with some sort of gait analysis, right? Where's that potential weak spot? What could be the ache in this situation? And for me, it's always, like I said, it's a test, retest. It's a trial and error to really see what is causing it, to see if we can create any remedies with it. But it's
Gotcha.
Looking at the person as a whole. It's looking at the whole chain. It's not just looking at the ankle itself. Because what's interesting and what's important to note about the ankle is it's bearing a significant amount of body weight, right? So that's also other things to look at too.
Absolutely. And Dr. Thompson, from a surgical standpoint, surgeries on the ankle, in general, do you have any thoughts about that?
So similar to the great toe, we have 2 options, right? You can either, if you've got to the point where you need surgery, you get to the point where you're sick and tired of being sick and tired, either a fusion or a total joint replacement. Both are good options. A fusion we typically use for more active patients just because it is more sturdy, and younger patients we tend to use it for because it is really more of a long-term sturdier solution, has a lot of evidence for long-term stability. The ankle replacement, though, allows for that continued range of motion, but you're kind of, its shelf life, so to speak, is not 50 years. It's more like 15 to 20 years before you might need a revision for that. So those are the things to think about. That being said, they both have really good evidence of improved pain, improved quality of life if you get to that point.
Great. Well, that's good to know. Again, whether it's the big toe or the ankle, if you have to get a surgery, at least we know that there's some surgeries that work. So if you're sick and tired of being sick and tired, you don't have to be sick and tired anymore, which is nice. Okay, so we're going to close it out with one final comment from each of our panelists. Okay, now the closing question for each of you, and I'm going to start with Dr. Weiner, is what is your one tip or trick or your advice for pain management involving the below the waist joint arthritis?
Sure. So I'll give a classic OT ergonomist advice, and that would be work smarter, not harder. So sometimes we have to rethink the way that we do things. When our day-to-day activities become challenging because of chronic pain, we can re-envision a way of doing it, using a different tool, using an assistive device. And it can be really hard to change your habits around the things that we do that are maybe personal, or the things that we have done the same way for our entire lives. But I would just say, open your mind to doing tasks differently, and then your performance will increase.
I love it. That's great. Dr. Thompson, why don't you bring us around the horn?
So I would say, kind of going along with that theme is to remain active, and active for different people looks different. And if you can no longer, again, for me being a surgeon, if you can no longer do those activities, even if you've made those adjustments, and enjoy life to its fullest. And again, that looks different for every person. That's when you really want to seek out a surgeon's help, not before, just because an x-ray kind of looks like you should.
I like it. Dr. Berner?
Yeah, so I guess the biggest thing for me is just, getting across the understanding that pain is always not just associated with movement, right? There's a psyche component. There's that underlying systemic inflammation in some cases where, how a person eats, how they recover, right? Meaning the amount of sleep that they get, how they manage their stress, and really how they maintain their engine per se. Okay? That's what really is going to, in most cases, affect an individual's perception of pain, right? So it's how we move, how we fuel, how we recover. And then with all of that, the connections and the relationships we have, kind of our mental health status as well, it's everything comes together, and it's going to affect that pain perception and that ability to move pain-free and do the things that you love.
I love it. And I think as I close it out, one of the things that I want to really highlight, and we didn't touch on it that much actually during this, but there is no magic pill, right? If there is one magic pill that could do everything, and you've all said it, it's exercise. And along with that comes a myriad of psychological and mental benefits, as well as physical. And along with that is weight loss as well. I think for a lot of the patients, and potentially some that are here listening in, weight loss is a huge added benefit, right? So there's not one pill. But if there is that one pill, it's exercise. And I think that there are a ton of things that come from that. And so if in whatever way you can exercise and you can move your body, do that. And there are ways that there are people that will help you do that. So that would be my lasting remark in that sense. Well, Robin, does that finish us off, or do we have any more time?
No, I think that wraps it up. And I just want to thank you all again for being here with us tonight and lending your time and your expertise. I think I can speak on behalf of our audience tonight that everybody feels much more empowered to take control of their pain and their symptoms. So thank you so much again, and take care. So before we sign off for tonight, there are a few reminders about upcoming events that I'd like to share from the foundation. So if we don't mind sharing that slide. The first off is our Facebook Live Fitness Solutions for Arthritis, Balance, Flexibility, and Therapeutic Exercises event. That's going to be September 27th from 6 to 7:15 Eastern Time. You'll learn the importance of flexibility and balance for arthritis, and learn how to incorporate benefits of functional movement, including yoga and Tai Chi, and other mindful exercises to improve your balance and flexibility. Moving along, our Eastern Medicine Body Treatments for Pain Management webinar, which will be on October 14th, features the director of UCLA East-West Medicine Program. You'll learn about key features of integrative and Chinese medicine to help manage joint pain, including a myriad of joint pain body treatments, such as acupuncture and acupressure. October 27th, we have our Fitness Solutions for Arthritis, Strength and Resistance Training. This is going to be an excellent panel with experts in PT, OT, and personal trainers from the American Council on Exercise and American Physical Therapy Association. You'll learn practical tips on how to cultivate a well-balanced strength routine, and all levels and fitness levels are welcome if you're here. Lastly, our All About Fats and Arthritis webinar is going to be November 10th. You'll learn the basics of fat and its role in an anti-inflammatory diet, including how much and when to eat, and including which kinds to avoid and which kinds to incorporate your diet. And as always, there will be ample time for Q&A for all of our webinars. Registration may not be open quite yet, but check back very soon on arthritis.org/webinars for more information and how to register. And then, of course, I encourage everyone to go to our Live Yes podcast and our Connect groups and our helpline for more ways to take control and manage your arthritis. We're always open for questions on the helpline. Lastly, like we mentioned before, the Insights Assessment is really crucial in helping us develop programs like this for your needs. So please, it just takes 10 minutes at arthritis.org/insights. And then just to wrap it up as a closing reminder, we will send a survey a few days after this event. So if you could just take a few minutes of your time to fill out the survey completely and honestly so that we know how you rated this program and how we can help improve events in the future. That's it. So thank you so much for joining us tonight, and everyone be well and take care.